So then we look at this question that's maybe more gets into more kind of moral ethical dilemma. But is it wrong to treat somebody against their will if they're likely to die if you don't? We've discussed it a little bit with patient X and do not resuscitate or do not use naloxone or opiate antagonist of any sort. Again, I guess it boils down to capacity, and the example that the physician posed or used was anorexia, which is a really strange. It's classified as a mental health disorder. I guess there's different forms of it, but it's a body dysmorphia that, these people who are suffering from this condition literally see or feel a reality that is different from what others are witnessing.
Mm-hmm.
So, I can't imagine having a loved one who's suffering from this and then having to section them or having to force food upon them. In some cases it's obviously the right thing to do. So here's a case where this has got nothing to do with drug addiction on the surface anyway. You could argue that there's some mechanisms that are the same as far as it being a coping mechanism, but really it's a mental health issue. The person is exhibiting signs of not being able to make a decision that's going to be good for their health long term. Therefore, we've made the decision as a society to our default setting is to intervene. And then I imagine, I guess you probably know a lot more about this, Corey, but if the person who's being held or treated against their wishes has been deemed unfit to make that decision, then how does that work with kind of executive control of the situation? Does it go to the spouse, the parent? Like who? There's got to be some kind of hierarchy there, I guess.
Yeah. I think if we're talking about in hospital, that can come back. The physicians are able to, again, to under the Mental Health Act, assume the role of the decision maker in those cases. But there are also, and I have seen cases of minors where the medical system sort of takes over, but I think they're with sort of support and collaboration from the parents. I've seen that as well.
What if the doctor is trying to keep the patient there in the hospital and is saying the treatment's necessary for that patient to survive, and the parent says, no, I'm taking my kid home? Where does what's the legal situation? Have you seen that before?
I have not seen that before.
Okay.
I've not seen that before. That's a great question. I'd be very curious to know what would happen there. This is a really tough one.
It is very tough. Yeah.
And it's, so I keep wanting to try to draw the line or sort of make the connection between a behavior like anorexia and a substance use disorder. And I don't know that they're that they can be compared fairly or be compared reasonably. I know that there are like that behavior of an individual to sort of act in a way that puts themselves at immediate risk. Though anorexia, there's more of a continuum there. Like the risk is assumed over a period of time versus in the context of our toxic drugs in our society, the risk can be immediate for someone who's using injectable opiates. So it's really tough. The other thing it kind of comes back to what we were saying in our last one about like, how are we going about this? There's a part of me that really thinks that the individual should be kept safe, and that sort of spiral of this sort of behavior that's gonna only lead one way, lead to their death, that should be prevented when possible. But what I have observed firsthand in my career was that we fall short. That I've seen forced eating before, or eat and we weigh you to see if you've gained weight, or else you might have to get a feeding tube put down your nose, kind of thing. And then we will weigh you, and we're not going to let you look at the scale, kind of a thing. And
so brutal.
So
it's such a tough situation.
It is. So what comes to mind for me too is like, is that harmful? Is the way that we are approaching this treatment causing some psychological injury to the individual by loss of autonomy, by feeling either abused or feeling powerless in that situation? And then also, are we getting to the root cause? And what I have observed in our current system is that we don't. That mental health in our hospitals means psychiatry. It does not mean psychology. And
right.
there's a very big distinction there. So a psychiatrist who would be involved, usually to prescribe a drug or drugs to help manage some of those symptoms of whatever the mental health condition is. But I have witnessed firsthand where the root cause, even when the root cause is like really obvious, when the root cause is trauma or grief, say, as an example, where that is overlooked, or where that is like not given as much weight as it probably should, where it's like, well, if you looked at the root cause of why this individual got here, and of course there's multiple factors that would lead to something like an eating disorder, but if you looked at some of those root causes and gave the individual the one-on-one time with a therapist or with a counselor, and where it wasn't just about like pharmaceuticals and this kind of like really kind of sterile forced treatment, to me, and I'm not the expert, but that seems to me like it would be of more advantage to the patient that way.
Yeah, I totally agree, especially with this condition or any eating disorder, but this one is particularly insidious. But I mean, I don't have a lot of exposure to patients or even friends or family who've suffered from this condition. But yeah, I from what I understand, I think it is maybe not only is it a part of the cause, a part of the treatment, but it's probably like 80 to 90% of the motivating factors for this particular. I mean, there's different categories of anorexia, but it seems to be largely psychological and usually from some past event. So I don't think we're doing anything with, I wonder why. I know there is treatment centers available and stuff like that, and again, there might be programs that exist like this, but maybe peer support would be something that would be useful here.
Yep.
To talk to somebody who's been through a similar situation and has come to terms with it, because I think that somebody who's in that spot probably is a lot like somebody who's deep into addiction and thinks it's a lost cause.
Yeah.
You know what I mean? Where it's like, I need to see from someone. I don't trust this doctor over here who just forced a tube down my nose and made me stand on a scale. I don't trust this person over here. I don't like this psychiatrist trying to put me on a pill. But here's somebody my own age, or maybe a little older, who's kind of got some ideas that might be helpful, just to kind of give you a chance of thinking, all right, maybe this condition can be sort of managed over time. And then that part of the puzzle perhaps should be addressed, like you said, more, it should be of more relevance than the way we have it set up now.
Yeah.
But I don't have much to offer in the way of expertise on this condition.
The other thing that, again, back to what we were saying before, we seem to, in our system, pick and choose what we have sort of a moral issue with. And morbid obesity is another thing that comes to mind, where I have witnessed certainly where people are treated with stigma and people are treated with judgment for their morbid obesity, but where they are certainly not detained under the Mental Health Act.
No, they're not.
Where they are not, forcibly made to see a psychiatrist and put on medications. I've seen really positive situations where they are supported, given autonomy, given choice, and said, we will kind of keep you here and help you get some physiotherapy and get some rehabilitation so you can get to a weight where then you could go and seek treatment, like a gastric bypass, for example. And just the treatment is obviously different than that of something like anorexia or bulimia, but there's also a vast difference in how much autonomy and choice the individual is given. And I can't help but think that we're kind of making that, again, we seem to be okay with people assuming long-term risk of death, but we're not okay with like a much shorter term. And now in our province, you look at the morbid obesity or cigarette smoking or alcohol, where it's going to potentially kill you over many, many years. Now we're looking at anorexia, where it could kill you over this amount of time. And now we're looking at the toxic drug crisis, where it could kill you in an instant. And now we're really not okay with it. And I just think, why are we making we're making a funny distinction there?
That's a really good point with the obesity one, because it's much more similar to drug addiction or using drugs to cope, right? I mean, there's even the parts of the brain that are involved are very similar. And I mean, what did they? I was just listening to a podcast yesterday, or the day before, and they're just on the verge in the States of, they're just under 50% of their population, slightly just under, but it's going to be in the next year or so, 50% of their population will be morbidly obese. Like, I mean, that is wild. Was it morbid or was it obese? Well, regardless, it doesn't matter.
Sure.
Maybe it's obese. Maybe it's not morbidly obese. You have a vastly increased risk of, all your cardiovascular stuff, stroke, heart attack. And that's not even mentioning the stuff it does to your frame down the line, with mobility and stuff like that. But we not only do we not intercede, but it's treated so carefully, right? Like, many physicians will. There's some who are pretty blunt about it, but others they skirt around it. If you look at the risk factors for somebody who's been obese for a long time, and they're getting, say they're getting into their 40s, 50s, they're really starting to get into the red zone as far as risk of heart attack and stroke and all that's concerned. The weight's not coming off. We don't seem to, like you said, step in, and nobody is demanding that those people, we're not forcing them to take stimulants or fat blockers or forcing them to exercise. We're not demanding that they get a gastric bypass or, have a procedure to slow them down. In fact, it's still kind of part of our culture, right? So why? And I guess maybe, again, it's the way that we're raised, and it's the way our culture looks at things. Because if we explained, or if everybody understood the risk factors properly, then it would make no sense. Why would you like, cannabis would be the biggest flaw here, the biggest heuristical error. Why in the hell would cannabis not be legal, but it's okay to be super obese and alcohol is fine?
Mm-hmm.
Like, that makes, there's no numbers that line up even close as far as, if you're concerned about safety, mental health, everything. I mean, anxiety, depression, all those things are higher for the person who's drinking too much and eating too much. So it's that's an interesting one for sure. And then the chronological point you make, like, is it just because of how much of a splash it makes? Like, it's hard for politicians. They can't hide the toxic drug crisis. They're doing a pretty good job of trying, but it's pretty in, like, everybody, I think at this point at least knows somebody who's died. It's like, and yeah, I don't know, maybe that plays a big role in it.
Yeah, and as does, and I won't go on I could go on a real tangent about it, but as does our society's crippling fear of death.
Yes, that's another thing I was recently discussing. What in the hell is with this? Go ahead. Sorry.
Oh no, just that. I don't have an answer to what is with it, but we are paralyzed with fear over death.
Yeah.
And I think our healthcare system lives in that kind of fear too. And the shorter term, or the sooner that could come, the scarier that it is.
Yeah, and we definitely tend to make more knee-jerk reactions. And
our ICUs, I think, are this is no criticism of intensive care. It is an essential part of our healthcare system, but I think that there are so many daily circumstances there that are emblematic of our society's crippling fear of death.
Mm-hmm.
And we could do a whole other episode on it because it's like such a big one. But yeah, it's a part of the conversation.
It is a part of the conversation, and it definitely plays in here. The other part of this that we kind of tied in was the religious aspect of it, where some cultures, some religions don't allow blood transfusions, and I thought that kind of, that's another perspective on the same thing. And I believe that I think I can remember when I was a kid, it was challenged a couple times or something, and
yep.
In the end, like currently, I believe it's perfectly fine to refuse a blood transfusion. Correct?
Yep.
Have you had patients do that?
I have.
Okay.
And I've seen that with again with minors as well, with someone who's below the age of consent where they have refused.
Wow. What an interesting situation there, eh? Now you got somebody they're not old enough to make important decisions like buying alcohol or cigarettes or gambling, but it's okay for them to decide not to get a possibly life-saving procedure based on a belief system. That's interesting.
Yeah, it's very interesting. That's again a really tough one. And so just even going back to the idea of an adult making that decision, we have accepted that is okay for them to make that decision.
Yes, which I agree with.
Same. Mm-hmm. Again, based on their faith, but the use of the word faith needs to be argued there too, because what someone values, what someone holds dear to them in one circumstance versus the individual down the hall who holds another whole other set of values dear, mm-hmm. based on all of their life circumstances and how they were raised and whatever it is that they believe in, or their relationship with the universe. They aren't able to sort of be their own decision maker. They aren't able to keep their autonomy. I don't know.
Yeah, I don't know either. And what if you got really crazy and decided that all of a sudden, what if we had a religion that was tied into the use of opiates, say, as part of their I don't know if this is, I mean, maybe you could say in Afghanistan or Pakistan, India, a little bit. I think they certainly have cultural tie-ins. I don't know if it goes as far as religious, if it's involved in religious ceremonies. Of course, other drugs are, but what if that was part of the puzzle or part of the problem they were facing politically, was that some people were claiming, that it's their God-given right to use every Thursday or something. Yeah. And regardless of the legal status, I mean, it really gets into some bizarre territory there for sure when you bring religion into it.
It does. And and again, I think the medical system is probably and quite understandably uncomfortable with it, because there's certainly I know that there are cases that have gone to court and have been big precedent setting cases, and I would imagine that any healthcare professional or physician would want to kind of not get into challenging that or setting a new precedent for it. But I don't know.
Well, we do have pharmacists who won't dispense like morning after pills
in our province.
Oh yeah, yeah, and that's their right, as long as there's another pharmacy within reasonable distance. Like that's how they've accommodated that, right? So if you're the only pharmacy in town, and you have a religious belief that strictly prohibits that medication being used, you still have to give it out according to the way those rules are
Wow.
set up. Like, you see how arbitrary and bizarre it gets, you know?
Yeah.